Chapter 69, Part 2, Lyme Disease. Lyme disease. This is one of those that I'm actually very afraid of. It's becoming very prevalent here, especially in Ohio and the Midwest where I'm at. It has a lot of very concerning side effects. It's becoming very, very prevalent, and there's also a lot of interesting conspiracy theories of where it originated from. It is the most common vector-borne disease in the United States, meaning it's transmitted by ticks. There's no person to person transmission. Being ticks, it's obviously peaking in the summertime. And it's especially common in the Northeast from Virginia to northern Maine, as well as in the Midwest, such as Wisconsin, Minnesota, or Ohio. It manifests, well, that hallmark manifestations is going to be a bullseye rash that occurs in about 80% of those, and will often appear within 1 month of exposure. It may also occur elsewhere on the body as the disease progresses, and is characterized by a central red macule or papule that expands to an outer red ring. It can also be warm to the touch, though not necessarily itchy or painful, and also occurs with acute flu-like symptoms like a low-grade fever, headache, neck stiffness, fatigue, and could possibly resolve in weeks to months, even without treatment. And here is just an example of that bullseye rash. Without treatment, it can spread within weeks or months to possibly the heart, the joints, or even the central nervous system. Arthritis is going to be the second most common symptom, as well as cardiac manifestations like palpitations, irregular heartbeat, neurologic issues like Bell's palsy, and brain and spinal cord inflammation, dizziness, shortness of breath, and numbness and tingling in the feet. When diagnosing Lyme disease, it's going to be based on manifestations and the history of the exposure, with the CDC recommending a two-step testing assay. It's going to be treated with antibiotics, many of which we talked about last term in pharmacology. Everything from doxycycline, amoxicillin, and some may even need extended antibiotic treatment, as the risks of untreated Lyme disease outweigh those of the long-term antibiotic therapy. Moving on to septic arthritis. In the case of septic arthritis, this is an infectious or bacterial arthritis where there's an infection within those joints. Microorganisms invade that joint cavity, and risk factors, things like diseases with decreased host resistance, corticosteroid or immunosuppression therapies, debilitating chronic illnesses, joint trauma, artificial joints, skin conditions, or IV drug use. The most affected joints would be the knees and hips, with symptoms ranging from severe pain, redness and swelling, fever, or even shaking and chills. Treatments also could result in aspiration or surgical drainage, with emergent to avoid any irreversible joint damage. It's also going to be treated with a broad spectrum antibiotic and IV transition to oral within 2 to 6 weeks. Let's move on to spondyloarthropathies. Spondyloarthropathies are a group of multi-system inflammatory disorders that affect the spine, peripheral joints, and periarticular structures. This is going to be things like ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. The primary symptoms are going to be pain in the lower back, as well as the hips. And this will be especially prevalent in the morning or after periods of inactivity. It can be difficult to distinguish in early stages of the disease, though it can also result in things like intestinal inflammation, psoriasis, and pain and redness of the eyes. Keep in mind, this is a chronic inflammatory disease that primarily affects the axial skeleton, that central spinal skeleton. Onset's typically in the 30s to 40s, though it can occur earlier in adolescence. Men are more likely to develop these, especially with the spinal damage we can see on the x-ray. The precise cause is unknown, though that HLA-B27 antigen is present in 90% of all patients, but only 8% of the general population. Clinical manifestations, again, it's going to be that inflammatory spinal pain as a first sign, as well as lower back pain, stiffness, and limitation of motion that's worse in the morning and night and improves with mild activity. It would also include things like uveitis that may be present before arthritic symptoms, as well as chest pain and sternocostal tenderness. Most patients with the condition stay fully independent and only may become minimally disabled. This would include things like postural abnormalities and deformities that can cause disability. There's also going to be a risk for aortic insufficiency or pulmonary fibrosis. Here we have a photograph of a patient with very advanced ankylosing spondylitis. Other diagnostic studies used be especially imaging, X-rays, MRIs, CTs. When caring for these patients, we want to decrease any pain and inflammation using things like heat, hydrotherapy, NSAIDs, and developing an exercise plan. For patient education, we want to look at disease and the principles of therapy, as well as assessing chest expansion, encouraging smoking cessation, and is also encouraging physical therapy focused on range of motion and exercises. In the case of psoriatic arthritis, this is a progressive inflammatory disorder that affects about one-third of people with psoriasis. It can occur in many different forms, so the most common being asymmetric oligoarthritis, where different joints on each side of the body are affected. You also may see symmetric polyarthritis, where joints on both sides of the body at the same time are affected, and this will more closely resemble rheumatoid arthritis. Other psoriatic arthritis is going to be distal interphalangeal predominant. This affects the ends of the fingers and toes, with pitting and color changes to the nails included as well. You may also see spondylitis or pain and stiffness in the spine and neck, as well as arthritis mutilans. This is the complete destruction of the small joints and is obviously the most severe. For psoriatic arthritis, we're going to diagnose it again, X-rays. Going to be looking at the joints, especially a pencil and cup deformity, as those joints are worn down from movement and a lack of cartilage. When considering options for treatment, things like splinting, joint protection, physical therapy, and again, those NSAIDs. Reactive arthritis, or Reiter's syndrome. This is a symptom of complex urethritis, conjunctivitis, and other lesions. Causes known, though believed to be triggered by specific gastrointestinal or genitourinary infections. Things like chlamydia, salmonella. Hematologic problems. These are going to be common, such as the formation of antibodies against blood cells, anemia, leukopenia, thrombocytopenia. Can also result in things like coagulation disorders that are likely to be resistant to any blood thinning effects of aspirin. Manifestations of reactive arthritis are things like urethritis that develops 1 to 2 weeks after sexual contact, followed by low-grade fever, conjunctivitis, and arthritis over the next several weeks. Women can also get cervicitis, and the arthritis last symptom to appear, things like asymmetric, involving the toes and large joints of the lower extremities. The treatment, most fully recover within a few months, though a few can develop chronic mild arthritis. The treatment's again based on symptoms. Doxycycline for patients and sexual partners, ophthalmic corticosteroids for uveitis, as well as NSAIDs for joint symptoms. Systemic lupus erythematosus. Lupus. Lupus is a multi-system inflammatory autoimmune disease. In this case, the body attacks everything. We think of lupus often as a disease resulting in kidney failure because that is often a very concerning symptom. It very commonly affects the kidneys, though this is an autoimmune condition that is affecting the entire body. Everything from the skin, the joints, the renal system, the hematologic system, as well as the nervous system. Lupus can also have a very unpredictable course with alternating periods of remission and worsening. In the US, there are approximately 1.5 million people living with the disease. 90% are females, though most develop the disease between ages 15 and 45. It has an unknown cause of abnormal immune responses, though most likely it has a major genetic influence, as well as hormones, infections, environmental factors like sun and UV light, as well as drugs that can occur months to years after continuous therapy with a caustic agent. It also results in autoantibodies made against single and double stranded DNA, as well as erythrocytes, coagulation proteins, lymphocytes, platelets. These autoimmune reactions are directed against the cell nucleus, and the circulating immune complexes can be deposited within the basement capillary membranes, things like the kidney, heart, skin, brain, and joints. The severity of lupus varies wildly, and it can range from relatively mild disorder to a rapidly progressive disease, affecting many other body systems. There's no characteristic pattern, though it most commonly affects again skin, muscles, the lining of the lungs, heart, nervous tissue, and kidneys. Here we have a diagram from the textbook, just going over all the different body systems that can be affected by lupus. The skin, the cardiopulmonary, urinary, musculoskeletal, reproductive, gastrointestinal, neurologic. It really is a condition that affects the entire body. Skin problems, these are going to be vascular skin lesions that can appear anywhere, most commonly in sun exposed areas. A rash may be the first symptom, though it may be limited to the skin. Could also involve oral and nasopharyngeal ulcers and even alopecia. Here we have a photo of a butterfly rash. This is a very common hallmark symptom of lupus, and that they get that butterfly rash along the bridge of the nose spreading out into the cheeks. For musculoskeletal problems, things like polyarthralgia with morning stiffness, this may precede the onset of multisystem disease by many years. It can also cause deformities such as swan neck deformities in the fingers, ulnar deviation, and also an increased risk of bone loss and fractures. Here we have a diagram showing that swan neck deformity. In that case, you'll notice that the tip of the finger is going forward as that middle knuckle is going inward. The cardiopulmonary problems can also take a lot of different manifestations. Tachypnea and cough, pleurisy, dysrhythmias, pericarditis, myocarditis, or even endocarditis. Renal problems. And this is often what kills many lupus patients. And that lupus, a lot of times when people think of lupus, they think of that renal failure. 40% develop kidney problems that need treatment and usually present within 5 years after diagnosis. Everything from scarring and permanent damage results in that damage to the functional unit of the kidneys, where these patients will eventually lead to go on dialysis or even transplants. For nervous system problems, neuropsychiatric manifestations are common and range from headaches to cerebrovascular disease. They're also going to be at a greatly increased risk for infection. This comes from an impaired ability to destroy the invading bacteria due to deficient production of antibodies and other immunosuppressive effects. For diagnostic studies, the diagnosis is going to be based on many different criteria. While there's no specific diagnostic test, you're going to be looking at things like antibodies, testing for any anti DNA proteins, and also looking for any expected immunologic disorders typical of lupus. For interprofessional care, this is going to be a major challenge to manage active disease, yet also prevent treatment complications. Survival is going to be influenced by a lot of different things, everything from age, gender, and having any other health problems and comorbidities. For drug therapy, we're going to use a lot of different drugs for this as well. NSAIDs for that mild joint pain, anti-malarial drugs for things like fatigue, skin and joint problems, reduced flares, and monitoring for any retinopathy with high doses. That's going to be a very common thing you see in NCLEX and ATI. As soon as you see these anti-malarial drugs like hydroxychloroquine or even ivermectin, make sure we're getting a baseline visual exam. That way, after we put the patient on the medication, we can very quickly identify if we're having any damage to the eyes from this medication. Other therapy would include immunosuppressive drugs, anticoagulants, and topical immunomodulators to deal with any serious skin conditions. Especially, again, remember that butterfly rash. That is going to be a hallmark sign of lupus. To the point where if you're sitting there on a test and you see butterfly rash, immediately be thinking lupus. When monitoring the disease management, again, we're going to be looking at those anti DNA titers and serum complements. When assessing these patients, we're going to be looking at everything from pain and fatigue, their ability to perform those activities of daily living, fever patterns, joint inflammation, limitations of motion, location, and degree of discomfort. We also want to carefully monitor everything from weight, fluid intake and output, and 24-hour urine samples, because again, we want to keep a very close eye on these kidneys. Other clinical problems include things like musculoskeletal problems, impaired role performance, and impaired tissue integrity. Before planning, these patients should have acceptable pain management, as well as show an awareness of and avoid activities that could worsen the disease. The unpredictable nature of lupus presents many challenges for both the patient as well as the caregiver. Again, lupus has a good prognosis for most people, though patient involvement is important. It's going to be a very complex treatment regimen. And they should also be aware that flares could happen. They could go through periods of exacerbation and remission. During flare-ups and exacerbation, the patient could be very ill very quickly. Again, fever, limitation of motion, neurologic issues, visual problems, headache, even on to seizures. For psychosocial issues, these patients are going to need emotional support, especially during flare-ups. Again, this is going to be a very complex treatment. It's going to affect both the patient as well as their immediate family. Another major consideration for a lot of patients is going to be pregnancy. Because again, which age group is most commonly affected by lupus? And that's going to be females in 20s, early 30s. And those are also the times when they're thinking of creating a family. And while they can become pregnant, they can build a family, they can successfully bear children. It also is going to create a lot of issues. It's going to be much harder for them. It is possible, but it's going to come with a lot of complications. For some patients, infertility may have occurred due to renal involvement, high doses of corticosteroids, and immunosuppressive drugs. They're also at a greatly increased risk for spontaneous abortions, stillbirths, and other serious complications. We also want to use energy conservation techniques. This is going to be a very difficult condition. These patients are going to tire out very quickly. First audience response question. A patient is undergoing diagnostic testing for symptoms of polyarthralgia, fatigue, and hair loss. Laboratory results include things like the presence of anti-DNA, anti-nuclear antibodies, and anti-Smith in the blood. The nurse recognizes that these findings are most likely to be related to which diagnosis? A. Systemic sclerosis, B. Rheumatoid arthritis, C. Chronic fatigue syndrome, or D. Systemic lupus erythematosus. That answer is going to be D. Systemic lupus erythematosus. Let's move on to scleroderma. Scleroderma is a connective tissue disorder characterized by fibrotic, degenerative, and sometimes inflammatory changes within the skin, blood vessels, skeletal muscles, and even internal organs. In the case of localized scleroderma, this mainly affects the skin. It's more common in children. In the case of systemic scleroderma, this is going to be more common in adults, with changes that progress rapidly and also involve internal organ involvement. The usual age of onset for scleroderma is 30 to 50 years, with about 300,000 in the US having the disease. It's also more common in females. The exact cause is unknown, though it's believed to develop to immunologic and vascular abnormalities. Risk factors include things like environmental or occupational exposure to coal, plastics, and silica dust. It can also be from an overproduction of collagen that causes progressive tissue fibrosis and blood vessel occlusions. Clinical manifestations are going to range from benign limited skin disease to a diffuse thickening with a rapidly progressive and widespread organ involvement. Diffuse scleroderma is again going to affect everything from the hands, arms, thighs, and chest to damage to the blood vessels themselves, including the heart, lungs, joints, muscles, or even the esophagus and intestines within the GI tract. Some patients with scleroderma have what's known as CREST syndrome. In this case, CREST stands for calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasis. Raynaud's phenomenon. This is the most common first sign, and it may precede some onset of systemic disease. In the case of Raynaud's, this is an overreaction of the vasospasm, very especially when you start getting into cold weather climates. When you walk out in the cold, your blood vessels constrict. Your body's trying to save that body heat. In the case of Raynaud's, it's a massive overreaction. And these patients will get to the point where their fingers will turn white, where it's cut off the entire blood flow. Some of the skin and joint changes would include things like symmetric, painless swelling or thickening in the fingers and hands. This may even progress to diffuse scleroderma of the trunk. Here we just have a diagram showing the sclerodactyly of a hand. In that case, we get that very fibrous, thickened skin tissue, causing deformities of the hand. The internal organ involvement can take many different forms as well. The first would be Sjogren's syndrome. In the case of Sjogren's, that's a autoimmune condition where it's actually attacking the lacrimal ducts as well as the salivary ducts, resulting in dry eyes and dry mouth. This can also cause things like dysphagia, gum disease, and dental decay. Esophageal fibrosis that can cause gastric acid reflux. Constipation from colonic hypomotility, or even diarrhea due to increased bacterial overgrowth. Other examples of internal organ involvement would be things like the lungs, with pleural thickening, pulmonary fibroses, and abnormal function. It can also affect the heart, such as pericarditis, pericardial effusions, or dysrhythmias. In the case of renal disease, this is previously a main cause of death, though treatment has improved. It's going to depend on early recognition and treatment. Things like dialysis, transplant. When diagnosing scleroderma, it's going to be based on the manifestations, since there's no specific lab testing. They can use this to rule out other diseases, such as assessing organ involvement or monitoring progression, but there is no specific lab specifically for scleroderma. For interprofessional care, we're going to be looking at vasoactive agents like calcium channel blockers or other therapies, specifically treating the diarrhea, treating the esophageal symptoms. This scleroderma has a lot of different manifestations, and our treatment's going to be based specifically on that. For nursing management, we're going to be, again, assessing vital signs, weight, input and output, and especially the joint range of motion. We also want to be careful to avoid things like stress or cold ambient temperatures. We also want to be careful on education, everything from no finger sticks for patients with Raynaud's, exercise programs, moist heat and paraffin baths, protect hands and feet carefully from cold, and also stress the importance of smoking cessation. As we talked about earlier with Sjogren's, this is something we're going to be very careful with. Xerostomia, other glands in the stomach, pancreas, intestines. We want to treat these specific symptoms. It's going to be, when we think of Sjogren's, we specifically think about dry eyes and dry mouth, but it can affect many other secreting organs of the body. Primary Sjogren's syndrome, this occurs when there's no other rheumatic diseases. It also has a secondary form that occurs in the combination with other rheumatic disease or autoimmune thyroid disorders that are also common comorbidities. As we talked about, this is an autoimmune condition. In this case, the lymphocytes actually attack those lacrimal and salivary glands. Results in that dry eyes, dry mouth. We're going to want to treat these dry eyes with artificial tears or ointment. We're also going to treat that dry mouth by focusing on things like dental hygiene and increasing humidity. Let's move on to myofascial pain syndrome. Myofascial pain syndrome is characterized by chronic muscle pain and tenderness, usually confined to one area within the chest, neck, shoulders, hips, or lower back. It may have potential infrequent symptoms such as muscle stiffness, fatigue, poor sleep, headaches, or postural abnormalities. The pain can often also be associated with connective tissue that worsens with activity or stress. It's diagnosed through eliminating other conditions through both imaging, testing, and also identifying trigger points, such as a cold laser wet or dry needling, electrical stimulation with electrode application, or transcutaneous electronic nerve stimulation. Treatment's gonna vary, everything from NSAIDs, lidocaine patches, muscle relaxants, physical therapy, behavior modification, or even heat, ultrasound, or massage, stressing, or even acupuncture. Next up is fibromyalgia. Fibromyalgia, or chronic central pain syndrome. This is a widespread, non-articular musculoskeletal pain and fatigue. It also is going to involve multiple tender points. It can have things like non-restorative sleep, morning stiffness, irritable bowel syndrome, or anxiety. Fibromyalgia is very common, affecting up to 4 million people in the US, with females being twice as likely. The most common cause of musculoskeletal pain in women aged 20 to 55, with symptoms usually appearing between ages 30 to 55. Fibromyalgia results from an abnormal central processing of nociceptive pain input from the central nervous system. Spinal fluid can contain proteins linked to neuroinflammation. And the greatest risk factors can range from genetics, people with autoimmune diseases, or even infection and trauma. Clinical manifestations would include things like widespread burning pain that fluctuates throughout the day, trouble determining if the pain is in the muscles, joints, or soft tissues, as well as head or facial pain from stiff or painful neck and shoulder muscles. Some of the common areas are going to be here in this diagram, especially looking along the back, along those shoulders, or the upper buttocks. Cognitive effects would range from a difficulty concentrating to memory lapses, feelings of being overwhelmed when dealing with multiple tasks, less able to manage stress, migraine headaches, and depression and anxiety. They'll often commonly report things like stiffness, non refreshing sleep, fatigue, paresthesia in the hands and feet, and restless leg syndrome. They also may have manifestations ranging from irritable bowel syndrome, difficulty swallowing, greater frequency of urination and urinary urgency, and for females, difficult menstruation with increased disease symptoms. A definitive diagnosis is going to be based on two elements: widespread pain index, where the pain in 11 of 18 tender points on palpation over the past week, and a history of widespread pain for at least 3 months. They're also going to have a score symptom severity index score, where if they score over 7, coinciding with things like fatigue, cognitive symptoms, and extensive somatic symptoms. Care is going to range from symptomatic treatment and the patient's needs consistent for support, as well as encouraging active participation in their treatment plan. Drug therapy may also involve things like Lyrica, Cymbalta, low-dose tricyclic antidepressants, SSRIs, or muscle relaxants. Care may also involve regular gentle exercise, things like yoga or Tai Chi, and massage combined with ultrasound. To help control symptoms may also limit the intake of sugar, caffeine, and alcohol, provide vitamin and mineral supplements, and help the patient to maintain a healthy weight. We also encourage common relaxation strategies such as biofeedback, imagery, or meditation. And finally, let's talk systemic exertion intolerance disease, SEID. This is a serious, complex, multi-system disease. Patients are unable to do usual activities and may even be bed confined. They can also have devastating impact on their lives and is a very poorly understood condition. This condition affects 800,000 to 2.5 million people in the US and is often underdiagnosed. It occurs 3 times more frequently in females and is more common in minorities and other socioeconomically disadvantaged groups. There is no precise mechanism identified, though many theories exist. Everything from neuroendocrine abnormalities, severe microorganisms being investigated, as well as changes in the central nervous system. The most common symptom is going to be severe fatigue, and can often be difficult to distinguish from fibromyalgia. It has a slow onset or intermittent episodes that become chronic and may be triggered by flu-like illnesses or acute stress. It also has associated symptoms that may vary in intensity, and patients will often feel angry or frustrated at a lack of diagnosis. Diagnostic studies would include things like physical assessment and other studies to rule out any other possibilities. While there's no specific laboratory test that can diagnose or measure the severity, in general, a diagnosis is an exclusion of other possible conditions. Our care is going to involve everything from support, teaching the patient about their condition, and drug therapy ranging from NSAIDs, antihistamines, tricyclic antidepressants, benzodiazepines like Klonopin or clonazepam, or even SSRIs. Activity, we want to avoid total rest, but we also want to avoid strenuous exertion that can exacerbate their symptoms. We want a gradual exercise program tailored specifically to that patient. We also want to make sure we're providing a well balanced diet, including fiber and dark colored fruits and vegetables. We also want to provide behavioral therapy. Many times this is going to have a very serious effect on their lives. Everything from not being able to work or decreased time being able to work, a loss of jobs leading to a loss of medical insurance, and difficulty in obtaining disability benefits that may be frustrating as this is a very hard disease to diagnose. These patients are going to face severe occupational and psychosocial loss. Many times will be labeled as lazy or crazy, is that there's no definitive diagnosis for this. These patients just feel very tired, fatigued. Most patients recover or gradually improve over time, however, and some do not show significant improvement. Recovery is more common with a sudden onset. But anyway, that's all we got for this chapter. I'll see you in the next slides.